Hi everyone, I'm Chloe Benedito presenting a patient care plan and discharge summary for major depressive disorder as part of mental health nursing course at Saskatchewan Polytechnic on October 14, 2025. Thanks to our instructor Sarah Full for her guidance. So MDD is a common condition that significantly impacts mood, thinking, and daily life, something future nurses would likely to encounter. Getting through severe depression isn't just waiting for the clouds to clear. It takes a solid, step by step plan. Today, we're going to walk through exactly how that plan comes together. First, we'll dive into what causes MDD, including the brain areas and neurotransmitters involved. Then, we'll introduce a patient nearing discharge and show how we translate their needs into nursing care plan with NANDA diagnosis, goals, interventions, and discharge outcome. Next, we'll tackle medication teaching and highlight community and crisis resources in Regina to support the patient upon discharge. And by the end of this session, you'll see how all these pieces fit together and understand how nurses provide holistic patient-centered care for someone living with MDD. So let's start with a quick overview of major depressive disorder or MDD. According to Bradley and colleagues, 2023 MDD is defined as depressed mood or loss of interest or pleasure in most activities for at least 2 weeks. This change affects person's social, work, or school functioning, and it's different from the usual mood. To meet the criteria for MDD, the person must have at least 5 of the following symptoms: irritable, depressed mood, loss of interest, pleasure in activities, noticeable weight change or loss due to appetite changes, change in activity level, fatigue, loss of energy, feeling guilt or worthless, trouble thinking, concentrating or making decisions, and sometimes thoughts of death or suicide. According to Pollard and Jakubek 2023, depression can result from a mix of biological, psychological, and social factors. Biological risk includes family history of depression, being female, and chronic illness like diabetes. Psychological factors includes early trauma and high stress sensitivity. Social factors involve isolation, life stressor like job loss, grief, poverty, and unstable housing. And lastly, substance use, especially alcohol or sedatives, can also increase the risk. While overall depression is multifactorial, it's usually caused by a combination of factors, not just one. According to Pollard and Jakubek, depression is linked to imbalance of neurotransmitters like serotonin, norepinephrine in certain parts of the brain. The limbic system controls emotions, so when it's affected, mood regulation becomes harder. The prefrontal cortex helps with decision making, memory, and emotional control, but its activity often decreases in depression. The anterior cingulate cortex also plays a role in emotion and decision making. And when levels of serotonin, norepinephrine, and dopamine drop or become dysregulated, it can lead to low mood, poor motivation, and loss of pleasure. So overall, depression involves changes in both brain chemistry and function. We'll call her Mrs. A. So here's a quick snapshot of Mrs. A. She's 46, a cisgender female living in Regina, and about 3 months ago, she was diagnosed with severe major depressive disorder following a job loss and divorce. She lives alone and on low income and has limited transportation. Her social support is minimal. She has occasional contact with her sister who has MDD as well, and she has weekly church attendance. Depression isn't just emotion, it's also physical. In just 1 month, Mrs. A lost 10% of her body weight due to loss of appetite. She also has type 2 diabetes, which adds another layer of complexity. Clinicians call the profound lack of pleasure or motivation she experienced as anhedonia. It's one of the hardest part of depression to overcome. You can imagine how draining it is both mentally and physically. So, with all these factors, her emotional state, physical health, and social challenges, the care team develops step by step recovery roadmap. This plan is tailored to help her mental health, physical health, and social situation. By understanding Mrs. A full picture, we can see why holistic nursing care is essential for helping patients with MDD to get back on track. Let's start with a quote from the person at the heart of our case study today. She said, "I committed unpardoned sins." Wow, that's not just sadness, it's deep, crushing sense of worthlessness. This feeling is a hallmark of the condition we're discussing today, major depressive disorder. Here's a snapshot of her clinical presentation. Regarding her mood, she felt empty and hopeless most of the days for 3 months. She has poor posture, facial expression was showing sadness and dejection. She has slow thinking and difficulty concentrating. She's unable to bat for 3 months, got decreased motivation, and shows some fidgeting. She shared that she once thought about writing a forlorn love note. She scored 21 on Hamilton Depression Rating Scale. So, as you can see, depression isn't just emotional, it affects thinking, physical health, daily functioning, and safety. When we understand this full picture, it becomes clear why a holistic patient centered care plan is essential for recovery. Therapeutic communication using open ended questions and reflective listening to enhance conversation and create an aha moments. By asking the right questions, you foster open dialogue while reflective listening ensures people feel acknowledged. Additionally, leveraging empathy promotes collaborative problem solving, validating others' feelings, and providing support. These skills build authentic connections and aid in overcoming life challenges. So for Mrs. A, the first thing I look was the most immediate dangers were. So it's kind of a triage in ER. Safety come first, then address in helping her basic self-care. The priority number one was the risk for self-directed violence related to feelings of hopelessness and passive suicidal ideation. We need Mrs. A to be able to report that she has no active plan or intent to harm herself. The second priority was self care deficit, especially with bathing and hygiene. The goal is to restore her routine. We want to get her to a place where she can handle basic hygiene on her own. Having these clear goals give the whole team something to work toward. The goals are great, but how do you actually get there? You need a toolbox, right? This is where the interventions come in. These are actual strategies and action used to help Mrs. A reach those goals. So to tackle the big safety risk, the team doesn't just hand down a list of rules that wouldn't work. Instead, they work with Mrs. A to build a safety plan together. This includes conducting a sad person scale assessment, removing immediate means of harm if present, sharing the Leave Life Support resource from WHO, creating a written safety stabilization plan, providing crisis number, and scheduling follow up. A close follow up, like phone call or outpatient visit within 48 to 72 hours. Now, for the self care goal, the strategy is all about building momentum. It's like trying to get a heavy flywheel spinning. You start with small, easy pushes. So you're not just saying, hey, go take shower for someone with severe depression. That can feel impossible, right? Instead, you break it down into tiny winnable steps. Things like, okay, let's just focus on washing your face. Then, great. Now let's brush your teeth. These are simple checklists, and every single time she checks something off, she gets encouragement. That positive reinforcement is what helps build the sense of I can do this. So here's how we evaluated progress for Mrs. A. First, under safety plan evaluation, the goal was for her to recognize warning signs and know what to do if her suicidal thoughts increase. Mrs. A was able to clearly verbalize her warning signs, name coping strategies, and list emergency contacts. She also stated she would reach out to support or crisis services if needed. She also signed a safety plan and was documented on her chart. She also scored 0 to 2 on sad person scale, which shows her risk were decreased. For self-care evaluation, we wanted to see her complete basic routine. Mrs. A was successfully following a morning routine checklist for 3 days in a row, either on a unit or during supervised community visit. She also reported feeling more in control and was able to start doing at least 2 hygiene tasks on her own without prompting. For this church, we focus on 2 main ideas. First, for risk of self-directed violence, Mrs. A has no active intent. A personalized safety plan, knew how to access crisis resources, and was using the Live Life, and also had a follow-up on mental health appointment within 7 days. Second, for self-care, she was completing basic ADLs with minimal prompts and reported more energy. She also had a support plan at home if she needed help, and these signs showed that she was safe and ready for discharge. When planning care for Mrs. A, several personal factors were considered. She's a middle-aged adult, so we focus on supporting her autonomy and using problem solving and connecting her with practical support like employment resources. Culturally, she's occasionally attending the church, so we explored spiritual support as a potential protective factor and offered faith-based resources if she was interested. She also has diabetes, so we have to coordinate with her primary care physician and monitor how her mood and blood sugar and medication might interact. Lastly, with low income and limited transportation, we included referrals to subsidized services, arranged follow-ups close to home, and provided some printed or phone resources. So, alongside all these therapeutic strategies, medication is another really important tool in the kit in Mrs. A's case, as she was prescribed with sertraline. You probably heard about it. It's a super common type of antidepressant called an SSRI. And the way it works in a nutshell is by increasing the amount of available serotonin in the brain. Serotonin is a chemical that helps regulate things like mood and energy. So boosting it can help lift that heavy fog over time. A huge part of the plan is making patient education, making sure they know how to manage their medication safely. And this was an extra important for Mrs. A because she also has type 2 diabetes. Some of these medications can actually mess with blood sugar levels, so she needs to be monitoring that. She also needs to stick to her diabetic meal plan and exercise regularly, since sertraline might increase appetite or cause weight changes. It's important that she stays mindful of that. And finally, she should avoid alcohol because it can interfere with blood sugar and also increase drowsiness. Patient needs to recognize common side effects like nausea, dry mouth, drowsiness, dizziness, and appetite changes. Serious side effects include suicidal thoughts, mood swings, and serotonin syndrome, which can cause confusion and rapid heartbeat. Severe symptoms should be reported immediately. And another big one is managing expectation. She has to know that it might take 4, maybe even 6 weeks to feel that full benefits. Knowing it's so important because it helps people stick with it even they don't feel better overnight. For discharge, Mrs. A should bring her medications to all follow-up appointments and carry a written safety plan with emergency contacts like 811, 988, and mobile crisis. She also needs to keep her follow-up appointments with community mental health and primary care within 7 days. It is important to plan transportation ahead, whether that is using bus routes, community support, or family rides. We also encourage her to reconnect with social supports like church group and sisters and to start scheduling activities gradually. Mrs. A doesn't just walk out the door with a bottle of pills. She lives with a safety net. This list here is her lifeline. It's a whole network of support in her community that she can tap on whenever she needs it. Mrs. A can contact the Canadian Mental Health Association for programs and peer support. The Regina Mental Health Clinic and Coast offer crisis and follow-up services, and Healthline 811 is available 24/7 for free advice and referrals. Just in case she needs, call 811. For crisis help in Regina, Mrs. A can call mobile crisis 24/7. She can also reach out to National Suicide Crisis Line by dialing or texting 988 for support and safety planning. So we've just seen what a detailed, thoughtful, and compassionate recovery plan looks like for one person. It really shows you what's possible when all the right pieces are in place, but it's kind of leave us with much bigger question, doesn't it? When you think about the millions of people out there who are just like Mrs. A, what does true community support for mental health really look like? And how do we build a world where this level of care isn't just a lucky break, but something everyone can count on? For my references, I use Canadian Mental Health Association Regina website, the NCLEX RN review book by Bradley and colleagues, drugs.com for information on sertraline, Barcarolis psychiatric nursing textbook, and Saskatchewan Healthline 811 website. This ends my presentation. Thank you very much.